So we're going to get moving now. We've got a first panel which is going to look at federal and provincial needs for serosurveillance. We have representation from across diverse constituencies, which is both here in the room and virtual. And so this is for our international visitors. This will give you a wonderful understanding of the Canadian context. To moderate this session, we have Sarah Viebeck. Sarah, who is the Chief Science Officer at the Public Health Agency of Canada and who was moderating for us yesterday morning, so I won't extend the introduction other than to extend thanks for her to moderate. Sarah.
Okay, one moment, colleagues. We're off to a great start. I'm your morning show again today, and thank you very much to colleagues for inviting me back. As I said, as Tim said, I'm really happy to be here as Chief Science Officer for the Public Health Agency and happy to be moderating this panel. We have a great set of folks in front of us. It's a hybrid panel today, and for those in the room, I'll invite you to come up and have a seat at the table. And for those joining online, I'll introduce you in just a moment. The focus of the panel this morning is on, come on up, it's okay. The focus of the panel this morning is on federal and provincial needs for serosurveillance. And we have a great set of folks joining us. So I will introduce them. Dr. Nadine Sikar is a public health and preventive medicine medical specialist working at the Public Health Agency of Canada. I have the pleasure of working with Nadine in my office as a senior medical advisor, and she also works with the infectious diseases and vaccination programs branch. Prior to joining the Public Health Agency, she held different positions at the local, regional, and provincial levels in public health organizations in Quebec, as well as Ottawa Public Health. Dr. Shelley Bolleton, and Shelley, can you hear us okay? A thumbs up would be helpful. Great. Shelley is the director of the Center for Vaccine Preventable Diseases. She's an associate professor at the Dalla Lana School of Public Health and in the Department of Laboratory Medicine and Pathobiology at the University of Toronto. She's a scientist at Public Health Ontario, and you heard from Shelley already about the iCare network, as I understand it, yesterday. At Public Health Ontario, Dr. Bolleton leads a SEREPI program to estimate population immunity to vaccine preventable diseases. We also have Dr. Carmen Charlton. Carmen, can you hear me okay? Okay, good. Joining us online, Dr. Charlton is a clinical microbiologist at Canadian Blood Services and an assistant professor in the Department of Laboratory Medicine and Pathology at the University of Alberta. She's also the virology program leader for prenatal and immunity screening and COVID serology at the Alberta Health Lab. Dr. Laurie Beach is a clinical biochemist and head of chemistry at the IWK Health Centre in Halifax, Nova Scotia. You're an hour ahead of us, so you will be more awake, I think, for the panel than some. She provides clinical service delivery in lab medicine, specializing in pediatric and maternal care. Dr. Beach is also an assistant professor in the Department of Pathology at Dalhousie, as well as the division head of public outreach and communications for the Canadian Society of Clinical Chemists. Dr. Derek Stein is with us. Thank you, Derek, is a scientist working at CADM Provincial Laboratory in Manitoba in the Department of Serology and Parasitology. He's also an assistant professor in medical microbiology and infectious disease at the University of Manitoba. His research interests are focused around understanding viral transmission dynamics and pathogenesis for CL4 restricted pathogens, as well as the characterization of existing novel disease models for emerging pathogens. And finally, last but not least, we have Are you the least awake, Ina? I don't know. From BC. Good morning. Dr. Ina Sekharov is a medical microbiologist in the Public Health Laboratory at BC Centre for Disease Control and the program head for tuberculosis and mycobacteriology laboratory. She's also a clinical assistant professor in the Department of Pathology and Laboratory Medicine at UBC. And her research interests include public health-related aspects of medical microbiology, clinical applications of microbial genomics and tuberculosis, as well as bacteriology diagnostic methods. So we have an amazing group of folks. Before we start, yesterday I acknowledged that we celebrated International Day for Women and Girls in Science, and I will this morning acknowledge the same thing. I'm going to give a shout out to Dr. Kate Hankins, who is this year a Canadian Medical Hall of Famer, which I think is pretty amazing. And also Dr. Deborah Money, who has been inducted to the Order of Canada. So colleagues, you're each going to have up to 5 minutes for opening remarks, and we will start with our colleagues on screen, Shelley and then Carmen. I'll time you, and then we'll have a moderated discussion with the audience. I'll remind folks that there's a microphone in the room, and is Varun still at the back for questions from online? He will be. We'll see you there, Varun. Okay, sounds good. Shelley, over to you, please.
Wonderful. Thank you. Can you hear me okay?
We can. Thank you.
Amazing. Thank you so much for having me. I'm really thrilled that we can get this group together for a discussion. And I'm going to talk a few minutes about the Ontario perspective, where at Public Health Ontario, we've been doing serosurveillance for about a decade for a variety of pathogens. We've done measles, varicella, mumps, hepatitis C, and of course, COVID-19. And through that, we've learned that expertise at the provincial level is important because provinces are uniquely positioned to know their respective population. And we also have close links with local public health. So with those two things together, we can understand where the specimens are coming from and who they represent. And that makes us well positioned to interpret findings. Furthermore, at the provincial level, we sometimes have the ability to link serosurvey data to other health or administrative databases, which allows us to have a lot more information about what's happening. And again, very important to understand who's being sampled. We have had several challenges doing serosurveys at the provincial level. One is, like other provinces, our population is very heterogeneous. So it's very difficult to obtain a sample that represents everyone. Particularly, we have difficulty obtaining specimens from particular groups. So children is one group, very hard to sample in a representative manner from children. Also, specimens from remote regions or populations that don't access healthcare in the same way as the general population. The last challenge I'll talk about, which is substantial, is advocating for and obtaining resources to do serosurveys on a regular basis. From a national perspective, I think that creating a national plan for serosurveillance is really important and very timely. The WHO recommends that we undertake serosurveillance at the country level for a variety of pathogens. So things like measles and rubella, hepatitis B, tetanus, and others. And so that's a nice thing when we're reporting to the international community. But I think regular serosurveys are also an essential part of pandemic preparedness, because in order to be able to rapidly do serosurveillance of the pandemic, we need to be doing some of the same work routinely in between pandemics. And that's to ensure that we have the expertise, the technical resources, and the experts that we need to interpret. We also need to have laboratory methods that are standardized across Canada if we want to do national serosurveys. And previous work, particularly during COVID, has shown us that this has been really difficult. So having national lab capacity is really helpful, both to standardize methods and also because serosurveillance methods can get quite specialized depending on the pathogen. And I don't think that there's one lab that has every single test available. So at Public Health Ontario, we've been really fortunate to collaborate with a national microbiology lab to ensure that our methods are robust. And I think the NML is a wonderful resource for something like this. So in conclusion, I think this is a great time to be discussing a national strategy. And I think that in Canada, we have all the ingredients required to be global leaders in this field. Thank you.
Thanks very much, Shelley. And we will turn it over to you, Carmen.
Well, I wanted to echo Shelley's thanks for inviting me. I think it's great to have this pan-Canada experience for what actually happened during the pandemic. And so at the time during the pandemic, I was working for Alberta Health Services as a clinical microbiologist and was really on the front lines of doing testing. And I think something that maybe is lost with when we start talking about serosurveillance is that the people that have the expertise for serosurveillance and work at this at a daily job, like the clinical microbiologists in any province, those are the same people that are now pulled to this very crazy, high demand, high stress, zero sleep time that you're now doing testing for a new pathogen. And so I think one of the things to do a really well thought out good serosurveillance is to have that capacity where someone like me who takes maternity leave in April of 2021 and who gets more sleep with a newborn than when I was doing clinical testing is not stretched in so many directions that things just can't get done. And I think that capacity is something that was definitely lacking and something that we didn't really anticipate because of the pandemic. And it definitely hindered, I know from Alberta's perspective, Alberta's ability to do serosurveillance projects. And while we were able to do some, there's also a lot of bureaucracy to get data. And I know Alton and Deb are probably in the room and know our intricate problems with getting data out of Alberta. But to really have a national surveillance, I think that we need to pre-plan these things. So we know that there's going to be another pathogen that we're going to be looking for. We know that there could be a range of different prevalence that it will start at. Maybe we should start thinking about these as a pre-populated like power analysis to say, okay, each province, we need agreements to get this many specimens from. They can be anonymized to begin with, because I feel like the data sharing is really what stops these studies. But to have anonymized look at where that pathogen is in the population, I think is really important. And if we have something up front and agreements that allow these regional differences, then we can move faster in something like the pandemic, where these clinical labs are now getting inundated with specimens. They're torn in multiple different directions. And there's also a lot of government pressure for external things. I think we talked about the snake oil lateral flow assays that came through. Those really hit a chord with our government, and we tested a lot of them early in the pandemic. And that again takes resources away from something that could be much more national and beneficial. So overall, I think a national surveillance is going to be really important when we do hit the next pandemic. And I think we have the right people in the room to talk about this. And I really feel that pre-planning and agreements before this hit are integral for something like this to actually go forward and be successful.
Thanks very much, Carmen. And now I'm going to work our way across the panel in the room, and we'll start with Ina.
Thank you very much. And thank you also for having me here. And I agree with everything that Shayla and Carmen have said. And in addition to that, I feel that we have our needs, as labs to be able to carry out serosurveillance, but ultimately the greatest need that we have is for those results to be needed by someone else. And if we are able to identify the appropriate stakeholders that can utilize these results for the purposes that they need, then we will have the buy-in and hopefully the maintained capacity to actually go forward and continue with our efforts. At the BC-CDC, we did not have an established serosurveillance program as a provincial lab up until COVID-19. And over the course of the COVID-19, we have built tremendous capacity as part of our research group to engage in a number of serosurveillance studies that now have transitioned from COVID to a number of other pathogens. I would really love to be able to maintain this capacity and, keep the trained personnel that we, took a long time to train. But again, to be able to do that, we need to demonstrate how the results that we produce are of tangible benefit to others. So the obvious stakeholders would be medical health officers, epidemiologists, and I think they do have like a certain extent of buy-in already, and they do have an interest. But to really make serosurveillance, or like blood-based surveillance of interest to the broader medical community, I think that we need to also be able to position it within the context of individualized, patient care. We all know that, healthcare systems in general, they're more focused on individualized patient care, and population health has often been neglected before the pandemic. And funnily enough, even so soon after pandemic, we already hear people saying that, they're being told that it's not sexy to, practice pandemic preparedness. And, I think we need to bring the sexy back. But, to be able to bring the sexy back, we need to demonstrate how these results actually do something for individual patients as well. So I think, being able to engage with, perhaps our hospital colleagues in demonstrating how, serosurveillance results have a tangible benefit to IPAC programs, working with the Ministry of Health to demonstrate how our results have an ability to, maybe optimize, individual patient health care through chronic disease surveillance, for example, or something, again, along the similar lines. I think that's something that we really need to engage in, and to be able to get that buy-in to, be able to maintain the capacity that we have built in our, in our laboratory. I'm sure that's the same situation for many others as well. And, if we do that, if we are able to demonstrate these tangible benefits, maybe we can sort of move beyond the hurdle of, nobody will thank you for the disease they didn't get, because we will be able to demonstrate how our results actually address the disease that do exist right now. So I think that engagement and, really educational efforts to demonstrate the tangible benefits would be something that is really necessary.
Thanks very much, Ina. Lori.
I'm not going to touch it. Okay.
May I just, sorry to interrupt you, Lori, can I just confirm Shelley and folks online, you can hear what's going on in their room? Yes? Good. Okay. Lori.
I saw them nodding, so that was good.
Good.
So we're going to go from the very west coast of Canada all the way to the very east coast of Canada, if you're not familiar with our geography. Nova Scotia experience that I'm familiar with was really with the antenatal studies. And from our experience, it really highlighted the need for collaboration, for something that's standardized, something that's ready to go. I think that there have been lots of conversations already about, access to samples, how do we share data, how do we get things stood up and running. But I would certainly echo the comments that came out earlier, where in some areas of Canada, you have a dedicated CDC. In other areas, you have a dedicated public health lab. That is not the case in some of our resource-challenged provinces and territories. Just for context, the population of all of Nova Scotia is just reached 1 million people, right? So if you put that in the context of a city like Toronto, or a suburb of Toronto, right, we're talking about a province that's trying to move things forward and stand things up, but with a much smaller base of people. I would advocate, though, that having that local data is still really important. Nova Scotia is probably one of the most important ports of entry for big ships, at least, in North America. It's got a massive natural harbor that does not freeze, and I think it might be one of the only ports that can, I'm talking outside of my area of specialty right now, but just for context, it can accept these giant ships. And what was interesting that we learned during the pandemic as well was just how differently local decision makers decided to treat things. For a period during the pandemic, Nova Scotia was essentially closed. Like, unless you had a child in another province or an emergency that you could go to the government and make your case that you need to leave and come back, it was closed. So it did mean that our serosurveillance and our seroprevalence data looked very different than some other provinces up until Omicron, which was pretty similar across the board. So I guess what I'm trying to get at is to say, I think it's really important, even for smaller locations or smaller sites. Sometimes geography makes it important. Sometimes, other factors do make it important to still have that local level data. And the challenge for some of the smaller places is just that we would value greatly the coming alongside of great collaborations with some other areas that have those things just ready to go. And that's it.
Thanks, Lori. Derek.
Yeah, so I thought I would take maybe a selfish approach to this and think really inward when it comes to Manitoba, because we've heard a lot about how we can work together nationally across Canada to really, and we've heard a lot of big themes like trying to get ethics approvals that are, pan-jurisdictional and data sharing agreements and things like that. But I want to talk about Manitoba a little bit internally. CADM Provincial Lab is the sole public health lab in Manitoba. We've got a staff of about 100. The serology department, we're about 20 people. And in that 20 people, we run about 1.5 million tests a year just for serology purposes. But it's really all infectious diseases. We run HIV, all the STBBIs, measles, mumps, rubella, all that sort of stuff. So all of that was at least in the context of the COVID pandemic, all of that still happened. And then we were asked by government, actually before CITF even approached us, to do COVID surveillance for the province. So one of the nice things about CADM, again, we are the sole lab, so a lot of samples for infectious disease purposes or even for routine prenatal panels and things like that, all are coming to CADM for those purposes. So we didn't have some of the challenges that some of the other provinces might have had with respect to reaching remote communities. All of that stuff is coming to CADM. So at least in our data, we were actually really fortunate to actually be able to look at pockets in all of our remote communities in northern Manitoba with respect to surveillance. One of the similar challenges that we had, though, was reaching school-age children and trying to get a really good assessment of what was going on with those, what was going on with that group. During COVID, most of the kids were actually not even going to school. So what little samples CADM does get is generally from children that are connected to the healthcare system because they're usually unwell or they're new infants. We're working up things for congenital syphilis, things like that, a more at-risk population. So we had some challenges along those roads. The ethics point of it, I just wanted to bring up, we submitted for ethics to our local university group, and we were lucky to have them say, well, this isn't even research. They didn't want to look at it. They said, no, you guys, this is surveillance. This is an emergency. So we had a lot of leeway, at least provincially, to do what we needed to do to get the data for the CITF and for the government. We were even able to link very early on all of our seroprevalence to vaccine records as well. So we were giving regular reports to our provincial vaccine panel, trying to figure out exactly how the, at least what we saw that was going on the ground in Manitoba was matching up with what NACI was recommending at the time. But really, I just wanted to finish up by saying CADM, we're really small. It was a big lift for us to get the COVID seroprevalence done. We have a lot of, we're a very small building. We have a lot of space issues. As I said, we've got maybe 20 people. They're mostly on clinical service. There's not a lot of people, space, and time to really push for this. So from a Manitoba standpoint, I would really advocate for those types of resources for us, at least for Manitoba, and really looking at like workflow initiatives and like different types of LIMS algorithms that we could implement that would take that big lift off of us and put it onto more automated systems. I've got 30 seconds. I think that's pretty much it. I've been selfish enough as it is, so I'll pass it off. I'll pass it off to my colleague here.
Thanks very much, Derek, and I believe Nadine has a few slides, if you wouldn't mind pulling those up.
Will I see them on the?
You've got them?
Got them?
There we go. Thanks.
Oh, okay. Sorry. Good morning, everyone. First, I'm going to bring us to take a little look back at where we started and what happened during COVID. The federal, provincial, and territorial Canadian Pandemic Influenza Preparedness document was really our plan that articulated roles or responsibilities at different levels of jurisdictions across a whole variety of topics related to the pandemic response. And in that plan, there was actually an outline of the role of serosurveys. And during COVID, we delivered on this commitment at our level, at a pan-Canadian level, by funding the CITF. And this was, we went for this approach instead of, for example, implementing a program within FACT per se. So this was the approach I was taking. And in addition to the funding for the projects for the CITF process, we also collaborated with CITF and StatCan on Statistics Canada on a large-scale survey to get a nationally representative picture, which was an innovative approach in the Canadian landscapes. And at this time, we are in the process of reviews and lessons learned for the COVID response, for science advice, more generally, research coordination for COVID in Canada, and also a review of the CITF is underway. And also underway are reviews of all our FACT surveillance systems and strategies, and there's also a refresh that's taking place of that Canadian Pandemic Influenza Preparedness Plan. So our future engagements and decision-making at the agency on serosurveillance would be considered in that broader context of that experience. In the context of this, towards the end of last year, internally at the agency, we have put together a working group of technical experts in the various program areas of the agency on a variety of communicable diseases and potentially other topics as well. And we have been trying to think about what could be the evidence needs that we would have and that could be informed by seroepidemiology. And first of all, of course, informing public health decision-making, and we've been talking about that, and we've been talking about that Monday quite a bit as well. And if we're looking at it from the lens of emerging pathogens or a pandemic, ongoing anonymized seroprevalence estimates by age group, and depending on the situation we're dealing with, potentially also by sex, may inform things like risk assessment, modeling, estimation of severity, and need for public health intervention. I think there were really good examples of that were discussed on Monday, so I feel like I'm repeating all the good points that were made earlier. But also, serology linked with other epidemiological indicators may inform the immunity profile of specific groups, maybe healthcare workers, or provide estimations of the impact of public health intervention. So there was a good discussion about this also earlier this week at this meeting about how, for example, when we weren't having we moved away from PCR testing and case-based surveillance, and there was less information available, how seroepidemiology was able to inform what was happening and how impactful the public health interventions were, including immunization. Also, if we look at some of our activities or mandates at the agency, we have several expert advisory groups or committees, such as NACI. That's a classic example, but there are others that may draw on seroepidemiology evidence as part of the entire body of evidence that you're reviewing. But in those circumstances, perhaps at times punctual serosurveys or specific studies may be better suited than surveillance depending on the topic. For example, when NACI made the statement on pertussis immunization in pregnancy, there was a serosurvey that was done at that time, but it was a punctual study. And finally, I want to talk a little bit about our FPT coordination mechanisms, federal, provincial, and territorial. This is under the umbrella of what we call the Pan-Canadian Public Health Network, and there's several associated committees from that, and where really we work together, the provinces, the territories, and the federal, the agency, but also other federal departments, other parts of the federal government, to identify what are the public health priorities. So, for example, the national immunization strategy will be under review in the following years, and some priorities identified and prioritized by provinces and territories might emerge from that. That could also be of interest in terms of seroepidemiology work. So I'm already over my 5 minutes. I will just talk about this last slide, which I think may be of interest. So as part of this work that I was mentioning earlier with our technical working group, thinking through some of potential use cases, it's still work in progress. We're still thinking through all of this. This is preliminary. But in terms of examples of possible use cases, we've identified pandemic readiness as a potential important use case, vaccine program evaluation, mosquito-borne and tick-borne diseases. There's a lot of discussion on tick-borne diseases on Monday. We're also seeing potential use cases related to mosquito-borne as well. And also monitor and report on our collective progress towards global eliminations of STBBIs. So it seems to me that we have a good concurrence between this and the discussion that we had on use cases on Monday. So that was very interesting for us to hear. So I think I'll stop here.
Okay, good.
Just have time. I also had a slide on challenges, but I think we can talk about that during the discussion. Thank you.
Good. Thank you. Thank you to the panel. We now have a good amount of time for discussion, and I'll remind folks that there is a microphone in the room, and I do see Varun back at the table to monitor questions from online. I think we heard some really interesting threads across speakers in this panel that echo what we heard yesterday and Wednesday, so lots of convergence coming out. One thread, I think, around the importance of standardized methods and tools, both in terms of sampling approaches, protocols, data sharing agreements across jurisdictions and institutions, the importance of retention of capacity, but also continuous skilling of that capacity. We also heard a bit about the importance of sharing and networking up that capacity, given that the capacity is not equally or equitably distributed across contexts. And that ties very closely to some points made around the diverse starting points to be able to scale up if needed in an emergency. We heard about transferability from COVID to other pathogens and the importance of learning there in order to demonstrate the value of the function, both for policy decisions, but as Ina said, also for guiding patient care decisions. I think there were some different perspectives around what a program in serosurveillance would look like. That could be a program that's really focused on preparedness for outbreak investigation or enhanced surveillance, punctual surveys for responses, or a routine platform for surveillance. We also heard that there could be benefits and connections to linking Sero data to other data, and I think you spoke to that nicely, Derek. From local context to global guidance, I think there were some helpful grounding points there from Shelley, and the importance of learning for how to gather data for harder to reach or harder to engage populations. And I think that that fits really well with what we heard in yesterday morning's panel around community engagement approaches. So those were some of the threads. I see we've already got a question at the mic, and so I'll turn it to you, Steve.
Thanks, Nadine, for mentioning Pilpin. There was a group of us who were involved with the Annex C document that Ted Kushak and Steve Guershow led for about 12 years, so from about 2006 to about 2018 until I went to Blood Services. And that document really was lab focused, but talked about things like how many specimens are we going to have to test, at what part of the pandemic, who are we going to have to engage. And we worked on this white paper, which was Annex C for over 12 years. In different versions and forms, and it got vetted. But more importantly, what it did was it brought a diverse group of folks together from national perspectives as well as provincial perspectives, and brought in international folks as well as some key leading epidemiologists like Danuta Skoronsky at the time. Linked us to vaccine effectiveness studies. That group, we did validation panels when EVD 68 came along, so stuff that had nothing to do with flu. We were engaged in drafting national case definitions for MERS and for H7 and 9. So I guess my question is there an opportunity at this point to create something like that where at least we can draft a relatively non-specific but still functional white paper that would allow us to build some basic principles so that even if the pathogen changed, we could gut it and work off what we had, and at least we build some or maintain these interconnections that spun off into other really productive and nationally important public health activities.
Good. Thanks, Steve. I'm going to take Sheila's question, and then we'll reflect on that from the panel. And I'll also just note that my colleague, Dawn Shepard, who's the Vice President of Infectious Diseases and Vaccinations Programs Branch, is also in the room today and may have some comments in response, Steve, to your question. So we'll pull him in. Just prepare yourself, Dawn. Sheila.
Yeah, one thing that I have over the course of the pandemic and in planning post-pandemic that has really perplexed me is how we could have national serosurveillance and still meet the needs of each of our regions. I've wrestled with this. To me, national serosurveillance sounds like a really awesome idea, and I can see the value, for example, for NACI in planning and understanding where things should be going. But the idea of coordinating it seems very difficult. The provinces each, the idea that sort of pops to mind is each province does the same thing, but it seems like that should work, but the priorities may be different. They have to allocate resources to things that may not be considered a priority. They also have to pay for it. They have to use common assays and common methodologies. And as soon as I start thinking that way, I think, oh, that sounds like that's going to be really hard to do. The Blood Service can do it, and we can cross all of these, most of the boundaries. But I don't know if that's what people want. And so I would like to put it to this SAGE group to give their opinion on how does national versus provincial or territorially, how could serosurveillance work?
Thanks, Sheila. And colleagues, we'll open up for comments, and I'll invite particularly some of our provincial colleagues to also reflect on the Canadian Public Health Lab Network. Dawn, I see you at the mic. I don't know if you want to take the first question. Yeah, sure.
Let me maybe weigh in because I'll jump off both of those, and thank you very much for that launch. First, though, before I start, I have to say, as the federal lead for pandemic preparedness and planning, the fact that you're saying it's not sexy is deeply wounding to me. I'm very hurt.
Others have said
And I note the timing that when I became responsible for it was right when it became not sexy, so it's even more wounding now. In all seriousness, though, that's a window, that's an opportunity. And as Nadine said, the conversations are live at the federal, provincial, territorial tables. We are refreshing what we affectionately know as the CPIP, the Pandemic Influenza Planning Guidance Document. You can see why we call it CPIP, into something that we're going to even more affectionately call the CPPP, the Canadian Pandemic Preparedness Plan. And that's very much live. Consultations are ongoing. We've identified what we think are the key priority areas, and nested in those key priority areas, which are still not locked in stone, but we have surveillance and diagnostic type strategies. So everything from the actual methodologies, the role of standardized tests, the role of the different jurisdictions in who's the reference lab and who's the doer, all of that is very much there at the wet lab kind of stage of it. And the data flow and the accessibility of data that was flagged earlier, that moves into the second piece on data. So there's very much an alignment with what we see needs to be part of the pandemic plan and what we're talking about here today. And yeah, a white paper could slide very nicely into the annex on serosurveillance in a Canadian pandemic preparedness plan. But there's a bigger piece that's going on at the agency, a bigger piece of reflection that I think we all need to acknowledge and be aware of. And the very biggest piece of that reflection is something that is the elephant in the room that no one wants to talk about. We are in a post-pandemic space. And there are two very push factors that are in this that we are pushing against. One is the antibodies to the discussion, because you're right, people don't think it's sexy anymore, people are sick of it. And so we are running into antibodies to discussion on pandemic preparedness, pandemic resources, and that is coinciding with a fiscal framework in this country which is not ideal. We are past the big check era. It is more with less, and it is likely in the public health space, and I think I speak for the provinces and territories as much as I do for the federal government, it is likely to be a do more and more with less and less over the next few years. So as we reflect in the agency on how we continue to deliver on our mandate in that space, we're asking ourselves some very difficult questions. And those difficult questions reflect on exactly what you just mentioned, which is, what is the federal role in surveillance? For every one of the 30 some odd surveillance systems that are in my branch, we are asking the question, what is the purpose of that system? What data at the national level are we generating that is a value add over what the provinces and territories are generating in and of themselves? Many of our systems are roll-up. Do you care, those of you living in BC, what is going on in Nova Scotia when it comes to rates of RSV? Maybe you do, maybe you don't. But we need to ask that question. And the same thing comes for serosurveillance nationally versus locally and regionally. Now, there are equity pieces, as my colleague from Nova Scotia has already pointed out. There are CDC-owning provinces, and there are less than 1 million people provinces, and there is a federal role in equity, so that certainly factors into the conversations. But we have jurisdictional roles, and we need to figure out not just it's your job, my job, but where's the value for what we're doing? Because we've been doing a lot of things for a lot of years. And we keep adding things, and they don't necessarily add the same value. All that to be said, we are looking at all those 32 systems, and I understand Jonathan Campbell gave a nice presentation on this a day or two ago. We want to know what the value is. What are people at the provincial and territorial level doing with our data? What are federal programs doing with our data? And what do we have to report internationally because it's important or our mandate or useful? And then how do we rank the importance of those things? Serosurveillance needs to fit into that space. Every single piece of surveillance technology or system that we have is going to be put to the scrutiny of the value proposition, the return on investment, and the unique role that only that system can cover off. Good example for serosurveillance that Tim and I were talking about earlier. Right now, everyone's worried about highly pathogenic avian influenza. Does anybody know how frequent it is spilling over into humans? Put up your hand if you do. I know how many human cases have been reported internationally. I can tell you to the digit, but that doesn't tell me how many cases are actually happening. There have been efforts to swab poultry workers in the UK. They're getting about 13% of poultry workers accepting to be swabbed, and the results are all over the map and not particularly helpful. is that a niche where serosurveillance of poultry workers would tell us how much asymptomatic infection is happening? And would it help us distinguish between true asymptomatic infection and a bunch of people that you swabbed the virus they inhaled 30 seconds ago from their nose and it isn't infecting them, it's just hanging out in their nose, and thank goodness PCR is so sensitive we found it. These are the questions that maybe serosurveillance is well equipped to answer. So elucidating where those true value propositions are for serosurveillance in the context of all of the other surveillance tools we have out there is going to be absolutely critical for this to move forward in the live warm base sense. No one will argue that we need the sleeper protocols, we need the reserve capacity, we need to think about how we have governance and how we do this again someday, but that's white papers and a bunch of things on paper. That's not resources, that's not people, that's not doing the doing. And we all know that those papers will get stale very, very fast if there isn't some sort of a churn warm base. So what does that warm base look like? That's the challenge that I want you to be thinking about when you're in this meeting. And how do we justify an investment at the provincial, territorial, or federal level in that warm base that keeps this alive and well enough that when we reach into the trunk to pull out any sleeper protocols when disease X hits, that we don't look at it and go, oh, they're gone, they're gone. We don't do that anymore. That technology is no good. And I have no idea how to get my samples to NML from Charlottetown. So those are just some things to think about, because there are opportunities in the conversations that are happening now, but there's also some very serious fiscal realities, and I'm not going to be shy about stating that that's the operating environment that we're all in. And if we're not realistic about things and we don't offer up solutions that are implementable, we're not actually being very useful with our time. Thanks.
Thanks, Don. And so I do want to return back to the comments from Sheila and Stephen. So there was a point really around collaboration for thought leadership, protocol development as part of broader preparedness efforts. I think it would be great to hear from some of our provincial colleagues about work within province related to pandemic planning, which I expect is also ongoing in addition to the FPT frame, and how serosurveys or serosurveillance are fitting in. And that I think ties really nicely to the question from Sheila, which is around the national picture relative to within province or even smaller units of analysis pictures for particular outbreak investigation. So I'm going to look for a signal for who'd like to weigh in on that from our panel. And in the absence of a signal, I may draw people in. Inna, please.
I can talk a little bit about maybe the provincial to federal transition. So, I mean, I agree that for some things, obviously, it's very useful to know what's happening in other provinces and other for other pathogens or other scenarios. It may be like really more sort of inwardly focused surveillance that's needed. And in terms of how to tie it from provincial to federal level, I mean, I think it will be hard to design at the federal level a system that will address every single provincial need. So from my perspective, it would be more important to have the provinces and territories actually, be the drivers of what the needs are and, like how exactly the system needs to look at their level. But as that happens, I think we all need to keep in mind that ultimately the ideal, scenario is that this data is then aggregated federally to inform the federal, the federal picture. So if, if we want to address particular provincial needs, focusing on specific regions, specific, health regions within the province, we still need to make sure that ultimately we have like a sufficient data set to move up, for joint federal analysis. So I think if, if we design locally, but, with the, keeping the federal needs in mind, in my mind, that's going to be the, preferred scenario. And in terms of sharing, provincial data at the federal level, again, I think the kind of analysis that you can do with the, the data for the whole country overall is probably going to, look quite different from, like what you can do at the provincial level. And the one thing that I would say would probably be counterproductive and that, we've seen sometimes with, not so much with serosurveillance, but with wastewater, like as when there is duplication of effort. And, like we've had, local provincial analysis that, we share back to our stakeholders, and then they see very similar sounding, but, different outcome analysis coming at the, from the federal level. And, I think that becomes, counterproductive and, kind of a waste of everybody's time because, why duplicate the effort? So, I think this is something, again, that needs to be coordinated up front to make sure that, analysis that, happen on the smaller scale happen where they belong, and, analysis that happen on the larger scale happen where they belong, and there isn't contradictory messaging that gets provided back to the people who look for the data.
Thanks, Ina. And given the comments from my colleague, I think probably even more important in a limited resource context that we're deploying those resources in a really highly coordinated way. Shelley or Carmen, I'm going to come to you and then we'll come back to the room.
Carmen, do you want to start or do you want me to start?
You can start, go for it.
Okay, I think the common thread that I am hearing is, maybe it's just because I come from a provincial perspective, is the need for provincial capacity. So I think, as Dawn said, white papers are great, but if there's nobody to do the work when the time comes, then we get into a situation that Carmen described, where individuals are being pulled in too many directions. What Sheila said really, really resonates with me. I do think that there is an essential role for provinces, both for using the data and also for interpreting the data. But I think that we can separate that from national level utility. I think there could be great utility at the national level, but a lot of the work can and maybe should be done provincially. Thank you.
And Derek, Lori, Nadine, any comments? And then Carmen, will pop back to you.
I would just agree with our panelists here. I really feel that the provincial priorities and needs really we should start there as a base and work our way up to the federal level. I don't, maybe I'm selfish, but I really feel like the provinces are Canada. Those priorities are Canadians' priorities, and that's where I feel we should drive from. I spent my whole career at the NML, so I've got a fairly federal-leaning point of view as well. But having spent time on the kind of the frontline level, I feel like those needs need to be pushed forward and really kind of become a base for what we need to do on a federal level. And there's national and international priorities as well that the feds have to also keep in mind. But really, provinces are Canadians, and so I feel like that's where we really should be starting. Yeah.
Thanks, Derek. Carmen.
So I'd agree with Derek and Shelley that I really think it should be provincially driven. And I think that the CITF serology working group that many of us were on actually really helped during the pandemic, because it brought all of the provinces and not just public health, but other things. I know Steve was on there from CBS at the time to discuss where our problems are, where we wanted to go, what we wanted to get out of it. And it was a real-time, highly populated meeting, so sometimes it was slower to act than maybe just a few of us together. But I think having that kind of diversity from everywhere, from a provincial level to a federal level, talking about the same issue actually was really beneficial. And we were able to move forward with how everyone was validating their assays as a very base level, and then get to how are we going to work with this to get surveillance going, and then layer that on. And I don't think that doing a white paper that Steve mentioned and surveillance need to be mutually exclusive. I think doing a white paper to bring the right people together to start that networking and bring those different perspectives together can then facilitate what we need to build as a network that is continually evergreen, so that, one day when I actually retire, which is a long, long time from now, hopefully, there will already be someone who's filling my position, for example, on there. and it's not static, and it's not something that what seemed like in Alberta, even though we absolutely had a pandemic plan, we pulled it out, and a lot of it didn't quite jive with what we needed to do for this current pandemic. So if you're continually evergreening a white document like Steve has suggested and overlaying that network on top, I think that that becomes very powerful.
Thanks, Carmen. Lori or Nadine, any other comments from you? And then Ray, we're coming to you at the mic.
I was just going to comment that the experience with the antenatal surveillance really highlighted for me how valuable it was to have some sort of a network and some sort of a help. If I had tried to do it by myself, I don't think it would have gotten done, right? But because we had that team of people who could have common language that we could use around REBs if we needed to use REBs, or data transfer agreements that had been successful in other jurisdictions, or an understanding of these are the assays that we prefer, but we will accept these ones because we think we know what we're going to do with them. Having that network in place was incredibly valuable in our jurisdiction, in my opinion. So as we talk about what solutions are going to work and are they going to be provincial and how do they dovetail with the federal, then I think that there will be continuing value in saying it might not be a single solution. It might be a solution that is scaled not just on, you know, how many people happen to live in a particular area and how many samples therefore are we going to use, but also scaled for the realm of the possible in those areas in a way that is fiscally responsible.
Anything to add?
Engagement with provinces and territories in terms of determining use cases, needs, what are the policy questions is certainly very important, so that we're talking about how can we ensure that the information is being used when there's a good alignment between the public health policy questions, even some of them are programmatic questions if they relate to optimizing immunization schedules or things like that, with the research activities or the surveys that are done. I think if the data that's being generated aligns with the questions that provinces and territories have, and that public health leadership are prioritizing, and then there's an opportunity for pan-Canadian initiatives in that space.
Thanks. Ray.
Thank you. I'd like to change the topic a bit to what we've heard about scarcity of resources, which is something which we all share. I've heard the situation of PHAC likened to the dismal state of the CBC. In order to avoid that, is there an opportunity or a responsibility for us at a provincial or federal level to be articulating our understanding of what should be done to the public, to politicians, in that we work in a political system, so we increase the size of the pie? Open to anyone.
I think that's probably a question for others in the room that may wish to weigh in on roles that folks outside of government may be in a position to play. So I will accept the provocation, Ray, and also bump it to others in the room. I don't see anybody else at the microphone. Varun, anybody online? Stephen, please come back to the mic. Thanks. I have a page and a half full of questions here, but I want to be fair to folks that have them in the room.
I actually like the comments of Don in the last comment. I mean, when we did Annex C, we actually thought that we might not have the resources to test. And so we need to build into these documents things like, can we pool serology? What happens if it's not flu? What happens if we can't? We always talked about whether we could even get stuff across borders. If we can't get testing across borders, then how do you do surveillance? And we shouldn't limit it to serosurveillance. I think we need to think about testing-based systems that can generate surveillance that may not be defined by clinical surveillance at the time as well. So I think we have to be very flexible and maybe building use cases that include, you know, we've had coronavirus 3 times in the last 20 years. Another coronavirus maybe not related to SARS, a disease X, a bacterial pathogen, and build out what we've talked about this week and say, these are what might happen. This is how we might do it. This is how we might plan for it. We're going to need to resources. And what happens if we can't get stuff across the border?
Thanks, Stephen. I heard a number of folks reflect in their remarks around some work that needs to also be done around harder to reach populations. And I'm thinking about the relationship, we talked yesterday about the relationship between areas where research questions can really be helpfully addressed by, you know, developing methodological innovation, and it sounds like that's one other area. And so in addition to what may be addressed through surveillance activities and through the public health system, there's probably also a set of research questions that can be very helpful to informing the science of serosurveillance. So I just wanted to put that in the mix. I'd like to turn our attention to building and retaining capacity. So a number of the speakers reflected on capacity issues. And I'm wondering about if you could reflect on the training needs within jurisdictions and what you believe the really core set of capacities within jurisdictions to be able to do serosurveillance are.
I can get started on that one as well. I suspect that the training needs would be, again, different, you know, between, you know, different provinces depending on their like base level capacity. I would say that from our perspective, what was really huge is to be able to, you know, get scientists on board that, you know, were really smart and, you know, really capable and really able to, you know, integrate the sort of, you know, quality systems that we normally use for diagnostic testing into serosurveillance activities to make sure that we produce high quality data, that, you know, samples are handled appropriately. And to me, having this, you know, like scientific capacity embedded within the public health lab was really quite key to, you know, be able to engage successfully in all of the serosurveillance studies that we did. And this would be really crucial to, you know, be able to maintain the scientific capacity and to have the, you know, systems recognize that, you know, there is the clinical aspect of public health labs, there is the technical aspect of public health lab, but we also do need to have the scientific, you know, scientific people on board who are dedicated to asking the research questions, you know, like making sure that, you know, there is ongoing, you know, like movement forward with respect to, you know, a methodological development. But, you know, like have that as their primary function and not be pulled in a million direction, you know, with, you know, like also addressing the clinical needs and, you know, other needs that, you know, will detract from successful implementation of surveillance programs.
Thanks, Ina. Shelley or Carmen? Maybe Carmen first.
Sure. The one thing that I did notice is that we have a lot of Masters of Public Health students coming out in Alberta specifically, and I know there's a lot of provinces have Masters of Public Health programs. I have acted as a practicum supervisor for a number of them over the years, and I would say even the ones who have excellent statistical analyses and who have done some epi really lack the clinical knowledge to be able to identify, you know, even if you're looking at something like syphilis, like the clinical testing is not straightforward. And so having to train someone who has the skill set that you need for epi on what a clinical testing is something that takes time. And while we can do this on a one-off basis through practicum projects for people who are interested in infectious disease, there seems to be a gap in that kind of knowledge, because everyone who's come aboard for ProvLab or for any of the infectious disease projects that I've done through the School of Public Health, that that section or that aspect of the training has not been there. And that's maybe something that public health lab, or not public health labs, but the public health schools could look at to see if there's maybe infectious disease training that we could do so that these people are not so naive when they're coming out, and that they have a baseline to kind of jump off of when they start their jobs.
Thanks for that, Carmen, and for drawing in that other sectoral perspective. Any other reflections on this? I have a follow-up question, but I also see we've got Dr. Shepherd back at the mic.
Actually, I want to build on that point.
Yeah, go for it, please.
I think that's a superb point. So when we're looking at what happened during the pandemic, and someone specifically raised how relaxing their pregnancy leave was after, or their maternity leave was after dealing with COVID, we all recognize that it wasn't just a human health resources issue in terms of doctors, nurses, PABs, and people in the healthcare system, but there was a marked shortage of public health expertise. And we can look at it solely from the point of view of increasing throughput or quality in public health schools or public health residencies and the like, and generating more people with better specialization in public health. But I think we're missing an opportunity, and that is to be integrating these sort of core expertises and competencies more broadly into the allied training program. So I'm an infectious disease physician. I can tell you the amount of public health training I got compared to the amount of public health training I've needed in my career, there's a few zeros missing in there. Now, granted, I trained in the days when the dinosaurs roamed the earth, and things have moved since then, but I think there's still a lot of room for us to look more broadly into nursing programs, into programs outside of public health in medical training programs, to work with the professional organizations like the Royal College and others to emphasize the fact that we need this as surge capacity so that you can have individuals who can actually pitch in and understand the fundamentals that you were just talking about. And that you know, we're not going to teach everybody the ins and outs of treponemal versus non-treponemal testing versus rapid testing and ever-nevers. I'm not suggesting we go to that level, but just the fundamental concepts of the basic principles of public health, epidemiology, outbreak, case and contact type stuff. I don't know about other health centers. Our health center had urologists and neurosurgeons managing COVID cases on the COVID wards because they couldn't do urology surgery and neurosurgery. The same concept, I think, can be applied to public health and making sure that we ground people better in that. So that's something the agency is really interested in doing and looking at our role in it, which is providing that opportunity for people to come in and actually do locums or internships or studentships or whatever they are to actually get that expertise inside the agency. And so that's a commitment my branch has to looking at opening the doors a little wider and getting people in. And it also has that added benefit of building a network, right? If you know who we are, you know what we do behind those closed doors, it's getting beyond spelling FAC and being able to understand that, oh yeah, there is someone whose job it is to do that, and I know how to get to them. And in the first days of COVID, we all know the hardest part was finding out who on earth was doing that and how to reach them. So building that ecosystem, that personal network, that getting people moving through the system, and whether it's moving PT to federal or federal to provincial and territorial or local up to, like, I think we need to do a little bit more of that, and it's that human network that really is what saves us when the chips are down.
Thanks, Don. I'd like to riff off of that, if I may, and it really is around a dimension of capacity related to relational capacity. I think that that's part of what has been really quite remarkable domestically in the pandemic response has been the establishment and strengthening of extramural scientific relationships. Our panel members themselves sometimes are cross-appointed to provincial contexts or federally and to academic institutions. We have strong intramural capacity, which I think that that folks have reflected on, but I'd love to hear the panel reflect a bit on the extramural capacity strengthening and how your thoughts on how that can be maintained in a go-forward context, because we have a room full of many esteemed extramural experts who are very keen to remain engaged in shaping this agenda, as we just heard from Ray and others. Shelley, I might come to you first on that, because you've got some great examples of intra-extramural collaboration.
Yes, everything that has been said really resonates. I think the thing that makes serosurveillance a little bit unique is it's like a team sport. No one person can do it alone. So you need microbiology that is very robust. We need to understand our test characteristics. It's a non-starter without that. But then you also need to be able to interpret. You need to have an idea of how to do statistical and epi analysis for population serology data. It's all a little bit niche, and one part can't function with the other. And so I think that calls for networking at the national level, because we don't all have all the skill sets. And I think that we're actually quite well positioned to be doing that from a timing perspective and from a goodwill and interest perspective, listening to this conversation.
Thanks, Shelley. In the room. Nadine, Lori, Derek, Ina.
I would just say I think it's a really easy. I've got a really easy solution in that.
Selfish?
It's not that selfish. Maybe it'll be selfish to everyone in the room here. Actually,
The question related to relational capacity.
Yes,
Derek.
yes.
Take the cue.
But I would say the easy solution is in maintaining these skill sets that we're talking about is to maintain the network that we have here today. That expertise has been built up. It can be, and if we maintain that expertise, I mean, everyone here is, we're youngish, but there's going to be turnover, and that if that network is in place, we will be the people that are training the next generation of serosurveillance experts and training them in those specific skill sets that everyone needs. And I mean, I think what we did really well was we have that micro expertise. We had that know-how expertise in at least generating the data. But again, we really struggled on the what to do with that data once we had it. And that's really been a big theme for this entire meeting, is that what's that value added? What do we do with this when we have it? And I think we've seen some really amazing use cases and the power that the surveillance that we can generate from this group can give benefit to Canadians. But yeah.
One of the things that had jumped to my mind is just even my own, whenever I go to a meeting, it's like, okay, what's my takeaway learning that I want to do? And I was reflecting at my table this morning that I was looking up, what courses I could audit, or could I do a master's in community health and epidemiology at Dalhousie, because I think public health is such a unique area in the sense that you have this incredible role in communication to the average Canadian of what it is that we're finding and seeing, as well as the scientific and the quality and the clinical, that like they can all come together. So for me, my takeaway is in my subspecialty, we don't necessarily talk a lot to public health, and we don't think about how what we do at clinical laboratory level might be important to public health. And I think that's something that can be adjusted. I would suggest that if there's a way to take your essential elements of what you need people to know and understand about how to translate things to public health and embed that in training programs, whether that's for your clinical subspecialties or your laboratory subspecialties, that might be hugely valuable as well. So I'm going to try to have a CSCC symposium about the interface between clinical laboratory and public health.
Hey, there we go. Challenge made, challenge accepted. That's awesome. Carmen, any comments from you? And then I'm going to come to the folks that are in the room.
No, nothing else on this one.
Good. So you got shortchanged yesterday by me when I was chairing the session yesterday morning. Please introduce yourself.
Hi, I'm Alton Russell. I'm an assistant professor at McGill, and I just want to comment on the training aspect from an academic perspective. So we have students who are very eager to analyze real data, to do stuff that can both be research and can inform public health. And I think that there's the connections that could be strengthened between academia and these labs so we can help you out. But I think that a lot of people like Carmen and we've been having these discussions where we've got plans where how we can work together to analyze data, but the data sharing and the barriers to that are what I think prevent some of these collaborations. And and I think that that maybe you could leverage the capacity that we have around data analysis much better if we could get over these roadblocks. So anyway, I just wanted to kind of share that perspective, and I think that maybe it should be a priority within the systems that are collecting and owning these data to try and make it easier to bring in students, to bring in faculty, so that we can not squander some of the value of these data because you don't have maybe some of the capacity to analyze it. We have the capacity, but we've got this wall in front of us where we can't actually get in and do it. So anyway, that was a comment.
Thank you, Alton. Why don't you chime in? And then Tim, are you also in queue? Yeah. Okay, thanks. Please introduce yourself. Yeah.
Hi, my name is Manasa, and as a recently minted public health master's student, I just wanted to provide my 2 cents and reflections. In addition to being a research assistant with HumanNet, I'm also working at FAC as a policy analyst with the Data Surveillance and Foresight branch. And I've only been there for 2 months, so I don't want to say anything that could risk or jeopardize my job. But I think what I've noticed so far, in addition to all the conversations about capacity building and our resource lacking environments that we're currently all grappling with, is I think the major value add of a network like HumanNet is the timeliness issue. So while the Public Health Agency and other federal initiatives are making all this great work to improve interoperability and data sharing, I don't foresee that happening in the next year, 2 years, 5 years, maybe 5 years, I'm not sure. While the work is being done, and while this evaluations of surveillance systems is being done, that's part of what my team does as well at FAC. I think the immediate concern is having that timely data on an ongoing basis and developing this network through HumanNet that can inform that decision making on the regular is what I feel like what this network really brings. And I'm just kind of wondering inputs or reflections on how we are going to make that happen in terms of developing those collaborative relationships between HumanNet, its network members, and the federal government. Thank you.
Thanks. And I guess you also mean other levels of government in your comments. Thanks for that. Tim, why don't we go to you, and then we'll return to the panel.
Shelley waving. I'm not sure she's waving
Shelley,
at me
sorry.
or not. Hi, Shelley.
Hi,
no, I think she wanted to get in.
You're waving in full size there, Shelley. Do you want to comment now?
I was going to respond, but I can also
please.
wait.
No, allez-y. Go ahead.
Okay. I feel that there's a lot of hand-wringing about fiscal constraints, and I'm 100% on board. But, FAC and other federal entities have made some really helpful investments in getting money places quickly, and the CITF is one great example. Another example is the Canadian Immunization Research Network, which has a role in serosurveillance for vaccine preventable diseases, but we also have a role for lab capacity for emerging pathogens. We are grateful for the funding. We're modestly funded, but we're very, very grateful for every penny. So while I completely agree that we need more capacity and we need more networking, et cetera, I just wanted to highlight the fact that, FAC has already done some work in this area.
Thanks, Shelley. And as Tim's coming to the mic, I'll just reflect that within the F in FPT framework, there's not only the Public Health Agency, there's the role of Health Canada, who, of course, transfer funding for health to provinces and territories. There's the CIHR, who have a role in accelerating some of the methods work, for example, that we've talked about over the last couple of days. And then there's also our colleagues at the Innovation, Science, and Economic Development department who are playing a leadership role in things like the biomanufacturing and life sciences strategy. And so there are all of those different elements of the system which are very relevant to our discussion over the last few days, but also the forward path for the country. And I'll just add that into the mix. Tim, please.
Great, thanks. And that sort of sets up one of my first comments, just putting on my dismal science hat as an economist. It would be great to get a sense of actually what the fiscal landscape looks like. And I know FAC has been doing its surveillance strategy. How much money is currently being spent on surveillance? And what is the time trend? And how much money has been spent on serosurveillance as a percentage of that? Because I think those basic figures are things that give you actually parameters to say, perhaps what Shelley's saying, which is actually there's quite a bit of money going, and it's not as if we have no monies. It's how we can deploy those, most effectively. So that those things I think would be important to get a sense of, and I know there's the surveillance strategy that's been up and going, and I understood that serosurveillance was a priority in the context of that, so I imagine that some sense of that distribution of resources in the bigger context of surveillance is sort of underway. Related to capacity, I just wanted to offer 3 thoughts on that, because I think it is fundamental, and I think there are different dimensions of it that are important in the context of the network moving forward. We don't have territorial representation on the panel, in part because one of our biggest serosurveillance advocates from the territories, Cami Kingdola, said to us in a rather dramatic way, she said, for me to do anything above and beyond what I've already got doing, what I'm already doing is almost impossible because I'm dealing with about 30 emergencies at the same time, and my office size is me plus 1. And so she said and she did something heroic on serosurveillance, despite the odds. And so the one dimension of the capacity is the absence. Right, it's almost a complete void. And I think in the context of the network, we have to be very sensitive to that, because if there are ways in which, and we have some good examples where we brought, we shone the light on what's happening in serosurveillance in Northwest Territories with working with CBS, but if we can engage that collective, then there are ways in which we can overcome the absence dimension. The second dimension of capacity is we have a latent capacity. And I think, Lori, in the context of antenatal surveillance, there's a huge latent capacity, because this is a program that works by decree to make sure that every person who's pregnant has the appropriate antenatal care. And part of that involves putting aside a blood sample for at least a year, right? Now, if you look at the extent to which we're tapping that capacity, it's rather concerning. And it relates to a whole set of issues that I don't think mothers and their children would look at and say are defensible reasons for not tapping that capacity. And so I think we need to bring that into attention as well, which is this is a latent capacity which has the opportunity to provide all sorts of insights on a critically important and massively representative, perhaps the most representative population across the country. But for reasons of bureaucracy, data sharing, lab networks, setups, et cetera, which are all human-made issues, we're saying it's impossible to fix. Okay, so that's the latent issue. And then we have what I call the misconnections opportunity with respect to capacity. And I think Alton was mentioning it, which is we have areas of interest and pools of reservoir of capacity, often in the academic centers, but not limited, that would love to be engaged in bottleneck areas of that information production value chain in the context of provincial health labs or other settings where there's an effort to try and make sense of surveillance data. And so the network function here, and we've got good representation, I think, of the academic world, but we could probably strengthen that in different ways and not simply through schools of public health. I think, Don, your comment on thinking about this in a broader alliance, because those different professionals and allied professionals all have interest and engagement in some part of the system, that may be another way of building those connections so that we can source in or insource valuable human resources. So those are just 3 thoughts on the capacity thing where we might want to pay attention in the context of the network moving forward.
Thank you, Tim, and a few better positioned to speak about capacity than an economist. I'm going to pass it to the panelists to offer their takeaways from this discussion and any challenges or provocations that they would like to leave the meeting attendees with. You have each got a couple of minutes, and I'm going to go to Nadine first, followed by the folks in the room, and then to Shelley and Carmen for last word. Thanks.
Over the past couple of days, there's been discussions at some point around some of the distinctions between research and surveillance, how surveillance is defined within the public health practice. I'd like to add another component to that, program evaluation, which is also another area of, which is another function, and where I think there's some value in thinking about how this could connect with the work of the network and the priorities of the provinces and territories. If I try to summarize like the words or the concepts, the thoughts that emerge from the conversation, I see kind of 4 or 5 things that we focus on, or through different angles. Utility, feasibility, both in terms of funding or technological challenges, laboratory sciences challenge. Sorry, this is my vocabulary of laboratory science is very limited, so apologies for that. So utility, feasibility, equity, considerations, both in terms of capacity between provinces and territories, but also in terms of groups of people that are disproportionately affected. And finally, the importance of collaboration and governance, and then ensuring that there's good engagement with provinces and territories. So that's what I'm left with at the end of this session.
Thank you, Nadine. I should have ended with you.
Oh.
Derek, to you.
Yeah, I would just kind of parrot back all the themes that we've kind of discussed over the last few days, particularly around building capacity, maintaining capacity, the sheer power of what serosurveillance can bring to the Canadian people in terms of value added, really, and then again, you know, the themes around ethics and data sharing, and to me, I don't understand these issues really. They just boggle my mind that we have these walls in front of us and we have all this amazing data, and we can't get through them. It's really frustrating from my point of view, but I'm hopeful that, you know, the pandemic has shown us that what can be done if we really want it to happen, and I would implore everyone to continue pushing for that.
Laurie.
From the conversation today, What I'm hopeful for the network is that we can agree on almost a harmonized pipeline that connects the science to the clinical lab to surveillance. Just thinking about capacity and the reality that just for the nuts and bolts of generating data in existing HHR situations, you know, we might have to move this out of the clinical lab. And what does that look like? And what does that infrastructure look like? And if we have a harmonized platform or a harmonized pipeline is what I'm thinking of right now, then we can share those resources or understand how that's going to move between those segments as seamlessly as possible so that it's still useful to the individual Canadian who we then need a clinical result for, but we can get the surveillance data that we need in a timely manner for the population level.
Thank you, Lori. Ina.
I have to say that the idea of trying to maximize the sort of, you know, built-in capacity across the health network really resonated with me, and I think it is important to try and embed education on public health and to a certain extent on lab sciences within, you know, different types of healthcare professions. And right now, Royal College is actually restructuring the model of education. I think this may be, you know, like a ripe and opportune time to actually try and do that. So that's one thing that I kind of, you know, I'm taking away from this panel. And then another one, what Tim said about, you know, the latent capacity in the system, and that, you know, like average mother and every child would be really, you know, incensed about us not being able to harness the potential of that latent capacity. I actually think we need to engage with the public more and actually have them as our ally in trying to, you know, bring down all of these barriers and, you know, being able to harness this, you know, have better outreach to the public, you know, like, you know, Sierra Tracker was really great with engaging, you know, with, you know, newspapers and, you know, like, you know, all sorts of media. Perhaps, you know, like maybe we can harness you people under 25, you know, like with engaging with, you know, Twitter and TikTok and, you know, like all sorts of other mechanisms to actually get the public more aware of all of the barriers that we are facing and, you know, have them be actually incensed about it and help bring these barriers down.
Ray is smiling and nodding from the audience. Carmen and then Shelley.
I think it's really heartening to hear the panel and the audience today that everyone is very keen on collaboration. And I think there's a lot of will from this group that we want to continue to work towards a Serosurveillance. And I'm hoping that HUMANET can continue that collaboration through the network, but also to help with some of these barriers that we're experiencing so that people who are willing to help with projects or to put their expertise together, like Shelley mentioned, having this diverse capacity that everyone's working together is so much more powerful than just me sitting in my office trying to do something and not being effective at it. So I really see that HUMANET's job is to continue that diverse network and to allow us to work together to bring those barriers down.
And Shelley.
I think that the panel in the room are a group of Serosurveillance enthusiasts, and I would recommend that we all advocate for more Serosurveillance as surveillance data, as research, as capacity building, each in our own professional area and our jurisdiction and whatever our niche is. I think that if each of us makes a strong case wherever we are, and we have a better chance of achieving that goal.
Thanks very much, Shelley, and to our panelists. I think we heard a lot today about actions from across different segments of the ecosystem that makes up public health, disciplinary, sectoral, intra and extramural. And I think that there's a lot of potential to continue that purposeful connectivity across those different dimensions moving forward. So thank you very much to our panelists. I'm going to invite you all in the room and online to show appreciation for them. And then I will turn it back over to Tim Evans, according to my notes, I think.